Okay, everyone, we're going to begin. First, I want to thank everyone for joining us this evening. We will be recording this lecture and sending out to everyone who is registered. Today's virtual community lecture will be given by Dr. Joseph Lee. Dr. Lee is an ABOS board certified fellowship trained spine surgeon. He graduated from the program of liberal medical education from Brown University Medical School. He performed his residency in orthopedic surgery at Columbia University in New York and followed with a fellowship in spine surgery at Rush University Medical Center in Chicago, Illinois. Dr. Lee has authored numerous publications and has presented at orthopedic meetings both nationally and internationally. His clinical interests include degenerative conditions of the cervical, thoracic, and lumbar spine, spine deformities, trauma, revision surgery, and spine tumors. Dr. Lee has conducted extensive research in the field of spine surgery and continues to actively do so. His research interests include intervertebral disc regeneration and minimally invasive spinal surgery. He is an active member of the North American Spine Society and the American Academy of Orthopedic Surgeons. Dr. Lee sees patients in our Tarrytown, New York location, which is at 658 White Plains Road in Tarrytown, also at 450 Mamaroneck Avenue in Harrison, New York, 645 Madison Avenue in Manhattan, and 50 Craig Road in Montvale, New Jersey. The topic Dr. Lee will be speaking on today is what's new in the treatment of back pain. If you have any questions throughout this lecture, you can type them down at the bottom. There's a Q&A section, and Dr. Lee will answer them at the end of the presentation. With that, I turn this over to Dr. Lee.
Thanks, John, for that kind introduction. I'm really excited to share my thoughts on a very, very common topic that we see as spine surgeons. Rothman's been a premier academic practice nationally, and we've been able to bring our model to the Westchester, New York, and North Jersey area, and we've been very excited to do so. So today's talk will focus on several things. We'll talk about kind of the causes of back pain, when to see a spine surgeon, and different treatment options that we have to treat this very common problem. So why do we talk about back pain? It's a very, very common problem that we see. Most people on this webinar will know somebody who's had significant back pain or themselves have experienced significant back pain. The really good news is that 90% of people will get better after an acute episode, and it can get better within the first 6 weeks of treatment. The problem is that the majority of those patients would experience a recurrent episode, and sometimes almost up to 10% of patients will have chronic low back pain. It's really the number one reason to still be out of work, and we spend an exorbitant amount of healthcare dollars on treating back pain. So we talk about, one of my favorite questions that I get in the office is this a genetic problem? And the two potential causes of back pain are either genetics or kind of wear and tear. This was an interesting study that started in the early 1990s. It was recently published in 2009. They followed or they identified multiple sets of twins, and they found that they followed these twins for decades. They noted that these twins had different occupations. They also looked at the impact of body weight, smoking, and they measured something called total body vibration, which was their equivalent of wear and tear. And they noted that about 25% of the time, they know that twins would have back pain that was not relevant to smoking, body weight, or wear and tear. And so they assume that there's a significant genetic component to the cause of development of back pain. This was another study that happened in 2011, This was done in Utah. They actually looked at 1 million Utah residents. They have a very large database there. And they were able to identify family members with complaints of degenerative disc disease and back pain. And you can see here that for patients with one relative of back pain, they almost had a 5 times risk of having back pain themselves. So again, these two studies show that back pain and the development of degenerative disc disease has a genetic component to it. However, we also know that mechanical problems or mechanical forces to the spine can lead to significant back issues as well. There are multiple studies showing that people who are heavy laborers have significant more back pain than people who are not. This was an interesting study in the 1970s. They attempted to assess the maximum amount of disc pressure seen with different body positions. I'm not sure this test would be ethical today. They placed a pressure transducer into a healthy disc, and they made these volunteers or test subjects assume certain positions. And what they noted that, if you can see in the diagram here, that laying down, or whether you're on your back or on your belly, you had very low pressure in your disc spaces. Sitting was actually worse than standing. And the highest amount of stress seen into the disc was when you were leaning forward, trying to lift something. So in our world today, where we do a lot of, 8-hour shifts in front of a computer, it actually is causing a lot of back issues, more so than when we just stand. And then obviously when you do any heavy lifting, that always does create a lot of strain on the disc that can lead to degeneration. So to me, I believe that the pathophysiology really involves both a genetic component, which we can't really control, and a mechanical component. So let's talk about the main 4 culprits of low back pain. One of the reasons why I went into orthopedics is we can identify anatomy, and when we find aberrant or abnormal anatomy, we can fix this. So the 4 causes of back pain are muscle, bone, disc, and nerve, and we'll talk of each one in detail. The number 1 cause of back pain is always muscle. Whether it's some type of strain, spasm. What typically happens is that our core muscles or back muscles are either weak or overworked. They get injured. They can experience micro tears of the fiber. When that occurs, you get significant inflammation in that area, and you develop scar tissue. Scar tissue doesn't heal. And then what ends up happening is you do something strenuous again, or you do something that puts your back at risk, and then you re-injure your scarred muscles. And then you get more muscle tearing, more bleeding, more inflammation, and more scarring. Here's a cross-sectional view of our lumbar MRI. And you can see the spine here in the middle, and then you see these color highlight of the muscles. And these muscles are actually the true core of the spine. When I see patients and they talk about working on their core strength, the six-pack muscle, which is the rectus abdominis, which is a important muscle overall, is not even close to where the spine is. And if you look here, these 4 sets of muscles are really the true inner core. And these are the muscles that, if you can build up, can allow protection of your spine. So when there's any force that's your body has to deal with, especially in the spine, all that force is not directed to the disc or the bone or the nerves, but really can be buffered by these muscles. The second common cause of back pain is disc pathology. The typical disc has 2 parts to it. There's the outer part, which is this tough fibrous membrane. We call it the annulus fibrosus. And it contains the inner jelly part, which is called the nucleus pulposus. The analogy that I commonly use is a jelly donut, where you have the outside part of the donut as the main structure of the disc, and then obviously the jelly part is the cushion inside the disc. The disc serves multiple purposes. It allows us to have motion through our spine. It creates space between our bones to allow for nerves to travel. There are different types of disc pathology that we can see. One of the most common ones that we'll see is something called an annular tear, where the outer ring of the disc experiences a small rupture. And it's seen here on the bottom left. You can see that little white signal here on the MRIs demonstrating a tear inside the disc. And this can be quite painful from a back pain standpoint. When you get an annular tear, it creates local inflammation at that site and can cause significant discomfort. Luckily, this type of problem usually resolves on its own. Annular tears can sometimes progress to herniated discs. And this is when the actual inner jelly part of the disc can migrate outside the fibrous ring and then compress the nerve. In the end, when discs continue to deteriorate, we see what we see on the bottom right hand called degenerative disc disease, where the actual entire structure of the disc, including the outer ring, the inner jelly part, continue to degenerate. You lose some hydration inside the disc. The bones start to collapse on each other. You get bone-on-bone bruising, and you get a combination of back pain as well as leg pain. So all three of these different pathologies are very commonly seen and can all cause our patients back pain. Degenerative disc disease is one of the most common pathologies that we'll see. The common term that we call is discogenic back pain. And the way we will hear about this from our patients is that they describe a lot of low back pain. That's especially worse when they are sitting for a long time, and especially when they transition from sitting to standing. It can be associated with leg pain. And on the MRI, as you can see, you'll see the collapse of the disc. You'll see that the vertebral bodies experience a little bit of shifting on each other. You'll see some inflammation in the end plates, which is what we call modic type changes. And all this can result in significant symptoms. Herniated disc is also another very common problem that we see that involves the disc. It's really most commonly seen at the bottom two levels, L4-5 and L5-S1. And the reason why is that these bottom discs experience the most force in our spine. When you get a herniated disc, patients will complain of back pain and radiculopathy. And radiculopathy is just a fancy term for sciatica, where people have pain, numbness, and tingling radiating down the leg. Typically at L4-5 and L5-S1, people will have buttock pain, pain radiating to the calf and to the foot. Patients will complain of worsening pain with coughing and sneezing or laughing, anything that will increase your intra-abdominal pressure that can get transmitted to the disc. Some of the physical exam maneuvers that we'll do is we'll raise your leg in the office and we'll see if that elicits some of the pain. The reason why that would occur is when we straighten your leg up, it does pull on the sciatic nerve. And if there's a large disc herniation in the spine, that maneuver will create quite a bit of discomfort. One of the things that we do get very nervous about is weakness in the leg, especially for disc pathologies at L4-5 and L5-S1. The particular weakness that we get most concerned about is a foot drop, where you know, when you're walking, you can't bring your ankles and your toes up. And so you notice yourself tripping. You notice that you feel like you're slapping your foot on the ground. Weakness is a sign that the nerve has become very damaged, and this would necessitate for the patients to come find medical help. The third cause is a combination of bone and nerve. And this manifests itself in something called spinal stenosis. Spinal stenosis is a disease of age. So if we all live long enough, we will all develop spinal stenosis. The classic presentation that patients will notice with spinal stenosis is back pain, buttock pain that is worse with standing and walking. So when you go to Whole Foods or the grocery store and you see people leaning on their shopping cart, some of this is a potential sign that people are suffering from spinal stenosis. And the reason why we call it the shopping cart sign is when people flex their spine forward, it actually takes some pressure off the nerves and people feel somewhat better. So typically what I'll ask patients in the office is, can you walk a mile? And if you can't walk a mile, I ask, if you walk for 10 minutes and then you have symptoms, if you sit down, does your pain get better immediately? And people say yes to that, then my assumption is that you have some degree of spinal stenosis. When you have spinal stenosis in this disease, we will see development of facet arthropathy, which are these joints in the back. You can see this normal axial MRI where this Y here is the joints in the back. And you can see these clean lines here. And these are the actual joints in the back. And so when there's really minimal disc pathology, these joints are very healthy. But just like any joint that we have in the body, whether it's in the knee or the shoulder or the hip, when you experience arthritis, you'll start to see that the joint space collapses. Sometimes there's excess fluid in there, and then we'll see bony spur formation. And you can see here where the nerve space gets very narrow because of a combination of bone spurs and hypertrophic ligamentum. And here's a good example on the left where the yellow indicates a normal nerve space. And then on the right, you can see this pink, what I call in the office a shark tooth type presentation when the nerve is very, very compressed. So this is a good example of a severe spinal stenosis. You can have other bony issues that can cause back pain. This is a very common problem that we see on the left side. The term is called Spondylolisthesis. It's in Latin, it really means a slippage of the spine where the actual vertebral bodies will slip on each other. And you can see here on the left, these vertical red lines indicate the posterior aspect of the bone. And here at the bottom level, you can see how these bones are malaligned. Sometimes we will see patients with significant scoliosis, and you can see the curvature of the spine. And we have multiple studies showing that people who suffer from scoliosis have more back pain than patients who do not have scoliosis. Spinal fractures are another common cause of back pain. The more common one that we see is fractures due to osteoporosis. Osteoporosis is a very, very difficult problem to treat. And thankfully, we have now very powerful medications that can help treat osteoporosis. I think about 20 years ago, the most famous drug for osteoporosis was Boniva. And you would see the Sally Fields commercial on TV talking about the benefits of it. But now we have significant advances in the treatment of osteoporosis. And bone health is so important in spine. The maximum bone density that we see typically in both male and female is around the age of 35 to 40. And then from that time on, your bone density actually starts to slowly decrease. And as people are living much longer, we're noticing that our patients in the 80, 90 range have severe osteoporosis, and this can lead to these fractures. Thankfully, we don't see this problem on the left quite frequently, but sometimes cancer from other parts of the body can spread to the spine, and it can weaken the bone and result in a pathologic fracture. And unfortunately, these fractures oftentimes require surgery. Now, we've talked about the 4 causes of orthopedic reasons for back pain, but there's actually a lot of times where there's a non-orthopedic issue for back pain. And half my job when I see patients in the office is to ensure it really is coming from the spine. When I say the spine, the muscle, bone, disc, and nerve, and not something else. So a very common alternative diagnosis is kidney pathology. The kidneys lay right next to the spine, and there's really not much separating the kidney from the back. It's really just muscle, subcutaneous fat, and skin. And you can have a bad kidney infection, kidney stones that can result in significant back pain. In our female population, OBGYN pathology such as fibroids, infections can cause low back pain as well. GI issues such as stomach ulcers or duodenal ulcers can cause back pain. And the other one that I typically see more and more frequently is autoimmune pathology. And this refers to rheumatoid arthritis, lupus, Sjogren's disease, some of these inflammatory arthropathies that are best managed by a rheumatologist. One of the most common ones that we'll see is something called sacroiliitis. This involves the inflammation of the sacroiliac joint. And you can see on the image, it's the joint that connects the sacrum, which is the bottom base bone of our spine, to our hip bone, which is called the ilium. And there's a very big joint there that is typically very stable, but we can see inflammation there. We typically see it in situations where someone has an autoimmune disease such as ankylosing spondylitis. Pregnancy can cause inflammation in this area where the hormones of pregnancy can weaken or loosen the ligaments there to allow for delivery. And there can be sometimes inflammation in those joints. One of the most common causes of sacroiliitis is actually a lumbar fusion. There's been studies to show that if you get a fusion in your lower back, that there's a 30 to 40% chance of developing sacroiliitis. One of the most challenging things that we have when we diagnose sacroiliitis is that when we see patients with this particular complaint, they present very similarly to someone with a disc herniation in the lower back. They'll have low back pain, buttock pain, and sometimes they'll have even pain right down the leg. There are particular exam maneuvers that we'll do in the office to see if this is a possible differential for us. But one of the best ways to identify it is with a sacroiliac injection. And this can help identify if this is the source of your pain. I typically like to think of sacroiliitis as a diagnosis of exclusion, where I like to rule out the lower back first. And if the lumbar spine does not demonstrate any significant pathology that can explain your clinical presentation, then we would start investigating for this particular pathology. There is a small MIS outpatient procedure that we can use to treat this problem, but this would be absolute last resort. So let's talk about how we treat back pain. And obviously assuming that's one of the muscle, bone, disc, and nerve issues. So obviously, any patient that comes into my office that doesn't have a significant neurologic deficit will undergo our initial non-operative treatment course. And it typically lasts anywhere from 4 to 6 weeks. It involves some combination of anti-inflammatories, and obviously Advils and Aleve are basic options, and we now have much stronger options. Muscle relaxers, pain medication are sometimes utilized in these acute settings of pain. Physical therapy is a very, very important part in our non-operative management. And I've seen so many patients who improve with just physical therapy. Injections can be considered if patients fail the medications and the therapy. And oftentimes I'll see if patients do therapy and they come back in 2 or 3 months, they notice about a 50-75% improvement. And it really is sometimes just time that makes our ailments go away. Physical therapy, like I said, is very, very important. In my practice, I tell patients, you always do some type of physical therapy and understand the challenges of COVID and economics. I really encourage patients to find 3 to 5 exercises that they can do by themselves every day, morning and night, for 2 to 3 minutes. Just like you brush your teeth without thinking about it, I would encourage people to create a stretching program for their back that they can do every day. And I think this can really help prevent development of back pain flare-ups. And obviously going to our therapy in Harrison or therapy offices locally to where you live, going once or twice and learning the exercises is incredibly beneficial. Additional non-op management alternative treatment options include chiropractor, acupuncture, yoga, ultrasound, electrical stimulation, and medical marijuana. Chiropractor has been shown that in the acute setting, a short course of chiropractor can be very helpful. Sometimes when patients are being told they need to come back 25, 30 times to do chiropractic sessions, in my opinion, I I don't think that's very effective. Medical marijuana is a interesting new development in some of our non-op pain management. Our practice at Rothman has a very a significant focus on non-opioid management of back pain. And we have multiple studies showing that medical marijuana can help alleviate some chronic low back pain, especially in patients who are not deemed to be surgical. And one of the most common things that I'll hear about patients or their fear about is that they don't want to get high. And obviously, we don't want people to get high either. We want people to have an alternative medication for them to take the edge off so they can function. And they can continue with the anti-inflammatories, the ice and heat, the home exercise program, that they are able to live with their back pain. And obviously, I'm a believer. This is my wife and I at a aerial yoga retreat. And this, in essence, is traction, where you're hanging upside down, you're letting gravity kind of take over and decompress the spine. And there's really some very good data to show the benefits of physical therapy, especially in the treatments of low back pain. And as a spine surgeon, this study really makes us question whether or not fusion surgery is a good option for people with just low back pain. This is a randomized control study, which is one of the higher quality type studies that we have. And this was done in Sweden, where they took about 65 patients who had low back pain as the primary complaint. On their MRI, they had degenerative disc disease from the bottom two levels. And they split the two groups up into having a lumbar spinal fusion surgery versus having physical therapy 3 times a day for 3 weeks, as well as something called cognitive behavioral therapy. And what that really is teaching patients to not have fear that the activity that they're about to do is going to cause them pain. And they followed them up for 1 year, and they measured certain parameters to assess their outcomes. And you can see here that at the end of 1 year, both groups were incredibly similar. So the fusion group, the physical therapy and cognitive behavioral therapy group, both groups had significant reduction in your disability index and what they qualified as a successful case. In spine surgery, in the spine surgery group, they noted 18% of complication, which they didn't see obviously in the non-op group. And they saw no difference in the use of narcotics, depression, anxiety, overall life satisfaction, return to work. So this is a very good study that shows the importance of doing physical therapy prior to anything definitive such as surgery for the condition of low back pain. Injections are another option if you fail physical therapy. We have 2 excellent pain doctors that can perform these injections in our offices. And these are really helpful for people who have annular tears or disc herniations that are causing significant back pain. And this is, again, another high quality study in one of the most famous journals in our medical literature, where they evaluate patients who had steroid injections versus steroid and lidocaine. And they noted that patients were significantly better after these injections. So for the presence of low back pain, there are a lot of non-operative options, and I consider injections to be non-operative, that can really address back pain. And there's some high quality studies to show their effectiveness. This is a more recent development and a recent treatment option that has recently been approved by insurances, and it may be a candidate option after traditional injections. It is called the Intercept procedure, and the procedure actually targets the basivertebral nerve. And if you look at this spine model on the right, you'll see this yellow nerve that comes in the back of the bone and arborizes to the end plates. And so we theorize that the cause of back pain, the actual symptom of back pain, may not necessarily be the disc, because the disc is avascular and doesn't really have a lot of good blood flow, or nerve issues, but it's actually the end plate, the edges of the bone that contact the disc. And this study or this procedure, they actually inject a cannula, which you can see down below, and they can actually ablate, which is a fancy way of saying microwaving that nerve, so the nerve no longer functions. And you can see here on the studies that they notice a significant reduction of pain score and your disability index in the treatment of low back pain. So this might be a very good option for someone who's tried the therapy for 6 weeks, who's tried medications, who's tried traditional epidural injections, and they have an MRI that shows a degenerative disc, and they are still in disabling pain and they don't want to have surgery. This may be a viable option. Now, when do we talk about surgery? And again, thankfully, it's very rare. Like I said, 90% of people will get better. For the other 10%, what can we offer? So, typically in our practice, the most common cause or reason to have spine surgery is for people who have back pain and they continue to have back pain after all the treatment options. And that's probably 90% of our practice. Sometimes we'll see patients with a neurologic deficit. And here on this particular MRI, you can see this massive disc herniation going into the spinal cord, and the spinal nerve sac, causing severe nerve compression. This particular patient has something called cauda equina syndrome, which is a surgical emergency. This particular problem results in severe back pain, bilateral leg symptoms. Oftentimes you'll feel numbness or paresthesias in your inner thighs and your genital region. And when this becomes a serious problem, we'll start to see patients experience bowel and bladder dysfunction. And if that's the case, this becomes a surgical emergency. So this is the type of patient that if I get a call from the emergency room at 2 a.m., we are operating within the first day of presentation. And obviously, we talked about patients with spinal cord compression that will require surgery. We'll sometimes see patients with severe trauma, like high-speed motor vehicle accidents that result in an unstable fracture. And if I got a nickel for every time people tell me a story about someone that they know that they had spine surgery and didn't get better, I could probably retire. But if half our job as spine surgeons is to pick the right person and the right patient to go through surgery. So we have this very famous study called the SPORT trial that was done at multiple institutions across America. And they randomized patients to having surgery versus non-op. And they followed them out for 8 years, which is pretty darn impressive. And they identified patients who had herniated discs, spinal stenosis, and spondylolisthesis, which are, again, all pathologies that we've described today on our talk. And they noted that in every single one of these particular pathologies, surgery is very effective in treating this particular problem. So let's talk about the actual surgeries themselves. Microdiscectomy is one of the most common procedures that we perform. Our incision is about 16 millimeters, so it's no bigger than a quarter. I do these surgeries through a tube, so it allows me to navigate through the muscular tissue. And when I'm done with the surgery, I can remove the tube and all the muscle fibers come back and minimizing some of the damage to the muscle. This is oftentimes done outpatient. People are walking out of the hospital. People have to behave for the first 2 weeks. And usually by 6 weeks, they're doing 90% of the activity. And again, it's a very, very effective procedure for someone with a herniated disc or spinal stenosis. Lumbar fusion surgery is commonly used for patients with the spondylolisthesis, people with scoliosis, and sometimes for degenerative disc disease. And here's an example of someone who underwent decompression and fusion, and you can see the screws and rods being placed into the spine to stabilize the segments. This is another patient of mine who you can see here on the left that has a very bad disc at the bottom level. And then you can see the pre-op x-ray and the post-op x-ray. And this is actually a fusion that we did a little bit differently. This is actually what Tiger Wood had done after all the other back surgeries he's had. And this is actually done through the abdomen. We can actually navigate through the abdominal contents, the great vessels, and place a biomechanically superior cage into the front of the spine and create this fixation through the device. And it allows us to restore the disc height, and we can get a fusion through the device. And most of my patients from this can go home 1 to 2 days after surgery, and there's no screws and rods to have to deal with. So this is a very effective procedure for a certain type of patient. And you can see how we've really improved that disc height at that L5-S1 level. There's been a lot of advances in how we perform surgery, and a lot of these options are available for us at Phelps and even at NYU. I've been doing minimally invasive surgery for the last 10 years. In my opinion, if there's a way I can treat someone minimally invasive, I would like to do it. Surgically, it's a little bit more challenging because we just are not able to see what we normally see in an open incision, an open case. But if we can help minimize some of the collateral muscle damage, muscle stripping, and some of the higher blood loss and the higher risk of infection, I think that's the best way to go. We now routinely use navigation, which is intraoperative imaging that we obtain of the spine. It allows us to navigate and place instrumentation with the highest precision. We are now currently using robotics as well to help us achieve some of our surgical goals. We now have very advanced instrumentation, as this evidenced by this cage demonstrated here on the lower left. And then we also have different ways of allowing us to treat patients' pain after surgery. So here's an example of traditional spine surgery. This is a big deformity case. And you can see this very large incision. It's about 12 inches, 16 inches. And you can see all this muscle here that's being held by the retractors. So you can only imagine how much pain this person will be in after spine surgery. Now, you can often do fusion surgeries through very small incisions. And this is an example of someone who's had that spondylolisthesis. And we can place the screws and cages through 2 incisions that look like this. And if I were to have a single level fusion, this would be my preferred approach. Now, the studies show that at 2 years, a lot of times the overall clinical outcomes are no different. So if you have to have open surgery because you have osteoporosis or for whatever reason, it doesn't mean that you shouldn't get surgery, because the overall outcomes at 2 years are equivalent. But the MIS technique, in my opinion, you have less blood loss, less risk of infection. In my experience, people get back to their life living much more quickly. Now, sometimes patients can have back pain even after surgery, and it's pretty disheartening for patients who entrust us to help them deal with their symptoms. And a lot of times we have to investigate why. So one of the most common causes of back pain after a microdiscectomy or a laminectomy is when you notice a further degeneration of the disc. So when we do laminectomies, we're not stabilizing the spine. And so the disc actually is still able to degrade as you get a little bit older. So, sometimes when I have patients who are very young in my practice, I get worried about them long-term because they've already had spine surgery when they're 35. And if they live to 70, the concern is that the disc will get worse. Sometimes we'll see problems not at the level where we did surgery, but at the level above and below where we did the surgery. And some of this could be due to the natural history of this disease. And some people theorize that when you do a fusion at one level and you allow the patient to return back to life in some capacity, they put more strain or stress at the other levels, and we do see some accelerated breakdown there, and that's called adjacent segment disease. Sometimes in our patients with pseudoarthrosis, with fusion, the fusion doesn't take hold, and we see someone experience pseudoarthrosis where the actual fusion doesn't take, these screws become loose, and there's a mechanical failure of the construct. And we typically see this in people who are poorly controlled diabetics, people who are heavy smokers, or people who are on immunosuppressants. Infection can occur in surgery, and obviously we do our best to minimize that. But again, people who are heavy smokers and bad diabetics can be prone to infection. We can oftentimes see muscle damage. This is an MRI of somebody who had a big lumbar procedure. And you can see the two circles here in the front. These are the psoas muscles, and you can see how nice and black these muscles are, indicating a good, healthy muscle. And then here in the back, there's supposed to be that same black muscle there, but you can see how all of that muscle has disappeared. It's actually been replaced with fat, and it's rare, but sometimes the muscle gets significantly damaged from these open surgeries, and they have this significant back pain. And the last type that can occur is nerve scarring. And when we do spine surgery, especially with decompression and freeing of the nerves, we do have to gently manipulate the nerves, but even that gentle manipulation can result in some scarring of the nerves within the spinal fluid sac, and that can lead to back pain. So here's an example of a patient that I saw in the office who had a prior back fusion from L4 to S1. You can see the disc above. You see a little bit of scoliosis here where the bone is shifting laterally, and you can see on this particular view where the bone is pretty much bone on bone. And you can see this on the MRI where the disc is completely collapsed. And there's a variety of ways of treating this. I think if someone recommended to expose this all posteriorly again and to place a screw one level higher is a viable option. But I think that would result in a lot of potential complications like dural tears or infection. And so one of the techniques that I really like in patients who've already had multiple back surgeries and has a problem at the level above is to perform what we call a lateral fusion, where we actually, instead of approaching the spine from the front of the spine or the back of the spine, we actually come in from the side. And we're able to place a very large implant that allows us to restore the disc height, and then we can place a small plate onto the lateral side and create fixation. So again, this is a minimally invasive way of attacking a challenging problem that we will see. Here's an example of pseudoarthrosis. This is a patient that had surgery elsewhere, had a very long construct, and unfortunately, she's a heavy smoker. She came with significant back pain, and you can see here at the bottom of her construct that her screws were haloing inside the bone. What this really is an example of is the screw is window wipering within the bone. And so when we went in there, the screw had no purchase. And in fact, there was a cage that was placed in her spine, and this cage actually migrated into her spinal canal. And so she obviously required a revision surgery. We placed bigger screws, more instrumentation for fixation, and tamped the screw in. So obviously a challenging problem that we have, but obviously there are ways that we can, we have surgical ways to fix this. One of the other common things that we'll see is patients that come to me about a discussion of spinal cord stimulators. So to me, this is really a salvage procedure, in my opinion. Patients who've had multiple back surgeries, who have persistent back pain, persistent leg symptoms, and then we do the full workup, including CT and MRI, and we see really no structural reason for the pain, whether it's some residual nerve compression or adjacent segment disease, no sign of infection, and the fusion has taken hold very nicely. Sometimes in this particular patient population, we will recommend this spinal cord stimulator. And the way this device works is I tell patients in the office that it's like when you hit your knee against the corner of a coffee table, you have two fibers that send signals to the brain. You have pain fibers and pressure fibers. And so oftentimes when you hit the corner of the table with your knee, you will instinctively rub your knee really quickly to make it feel better. And what you're actually doing is you're overwhelming the brain from sensing pain versus pressure, which is obviously much more pleasant than pain. And when the pain fibers calm down because the pain source has gone away, you feel better. This is something similar. We have pain doctors who can do trials to see if this device actually works. And if you're a candidate for this, where they place these paddles and electrodes into your spine, and they have a different program that they can utilize to see if they can, quote unquote, trick the brain to sensing pain versus pressure. And this is something that our pain doctors can talk to you about as a possibility. And if it does work for you, then you can end up getting the actual permanent device placed in. And again, this would be a salvage procedure. I don't believe this to be a good solution for patients who've had significant primary spine pathology and never had any treatment done, because the stimulator is not going to fix the slip bone problem or the severe nerve compression problem or the fracture. This is really kind of a last-ditch effort, in my opinion, to help deal with patients who have had multiple surgeries. They don't want to go through any more traditional spine surgery, and they have severe pain, that this would be an option. So in conclusion, back pain is a very common problem. In my particular practice, I always believe in treating patients with the conservative route first. And really surgery is the last resort. And, it's patients who, in my practice, I really like to see patients who have back pain and leg symptoms. People with both back and leg symptoms do a lot better than people with just pure back pain after surgery. Obviously, weakness or bowel bladder issues, we need to do surgery sooner than later. And so just the last piece of advice, to me, this is so important. I think rather than letting things get out of control, we should all be very aggressive in being proactive in taking care of our back. If you see me in the office, one of my favorite phrases is motion is lotion for the spine. And what that really means is that we all need to take up a healthy back lifestyle in terms of low impact cardio exercises, core strengthening, really flexibility training is so important, and avoiding certain high risk things. And I think if we can continue to prescribe to that we can avoid the development of significant pathology that ends up requiring something more invasive like surgery. So with that, I thank you for your attention today. I hope it's been very informative for the participants, and we'll take some questions.
Yes, thank you, Dr. Lee. Very informative, especially your take on the minimally invasive spinal surgeries that are being performed. Very interesting. We do have a few questions. First question is, can teenagers have back pain? And with that, I'm assuming that it's without an event, just general back pain.
Yeah, so great question. Teenagers, unfortunately, can have back pain. Most of the times it's short-lived and it's usually muscular. But I've seen, especially in Westchester, a lot of our high-level athletes who play sports year-round and are very highly competitive and have aspirations for the next level. And I've oftentimes identified patients with stress fractures, and that's a very, very common cause of back pain. Sometimes it's pretty rare to see a bad herniated disc or degenerative disc in a teenager. So my differential would most likely be a stress fracture first, then a disc problem second. But to that question, yes, teenagers can have back pain. And the good news is that most teenagers will get better without need for surgery.
Great, thank you. This kind of goes with the first question. Do back stress fractures heal without surgery?
So that's a great question. So it depends. There's a spectrum of stress injuries to the spine. And the reason why they occur is that in teenagers or younger patient population, the fusion, the bone itself is not as mature as our bone when we're 21. And so if there's repetitive forces to the spine, such as people who are gymnasts, baseball players or football players, where they have repetitive extension type forces to their back, they can be a stress fracture or stress reaction to that lumbar vertebral, and it's typically L4, L5. And they don't get it worked up because they're young and they're still active and they can still play. They work through it, and they don't realize they actually have an injury. And so if it's a stress fracture, there's actually a fracture line through the bone. Oftentimes we will put people in braces. We actually shut down the activity for 3 months, and then we gradually build them back up over a span of 3 to 6 months. So, and hopefully the fracture can unite, but oftentimes we actually don't see the fracture heal. The scenario would be someone who has a stress reaction where instead of actual fracture line through the bone, we just see bruising within the actual bone. And those oftentimes can heal very well without need for surgery. And that oftentimes just heals with rest.
Great, thank you. Next question is, what exercise do you recommend for your back? And I would
imagine. Yeah, no, I'm probably one of the worst patients in the world. My 3 exercises that I do knees to the chest, I do double knees to the chest, I do a figure 4 exercise, and I do a hamstring stretch. And I do this for about 90 seconds, and then I get on my day.
Okay, fair enough. Thank you. How long after a lumbar fusion can another surgery be performed if adjacent segment disease has quickly set in, causing new and different pain?
So that's a great question. First off, you want to ensure that the first lumbar fusion has taken hold. And that process can take anywhere from 6 months to 9 months to really to mesh. And until that process occurs, it really becomes challenging to say what is the actual source of back pain. And once you can get definite evidence that the fusion has taken hold, then you can start investigating and seeing if the other discs are problematic. And we would have to get additional tests done to ensure that. It might require additional injections. And so our pain doctors can actually inject particular joints, and they can see if the joint above your fusion responds to an injection. If it does, then you may argue that that's the source of your pain. There are some newer imaging modalities that we can use to help identify joints or discs that are problematic. We routinely use these studies in cancer workup. And in the West Coast, this is being done a lot more than here in New York. One of the downsides is that's quite a bit of radiation to the patient, and it really is a non-specific test. Like an MRI gives me a crystal clear picture of what's going on. This particular CT scan kind of just shows me areas of problems, and it doesn't really say, is it a problem of a disc, or is it a problem of a joint? Is it an infection? Is it arthritis? It doesn't really say any of that. But it is another piece of information that we can use. And we do use this when we are concerned about people who've had a fusion done and they have additional problems at other segments or even at the index level.
Great, thank you. Next question is, can CBD oil have any benefit for back pain?
Yeah, so CBD is an alternative option. I am totally fine if patients want to try it. Uh, one of the issues with CBD is that it's not FDA regulated. So, what you're buying on Amazon or whatever place you're getting at, you don't really know what you're getting. I don't think it could hurt you. And if it helps you, I think that's a great blessing.
Great, thank you. Next question is, what is considered severe spinal stenosis?
Yeah, so in my opinion, severe spinal stenosis clinically is a patient who can't even stand or walk for 10 minutes. Some of the questions I'll ask is if you're standing and talking to a friend, or if you had a social event, are you always looking for a chair to sit down in? We have some objective studies showing that if you can't walk more than 30 minutes, that's a sign of significant stenosis. But you have to be careful with that because, some of my older patients, they can't walk 30 minutes, not because of their spine, but more so because they have heart issues or blood flow issues, et cetera. But, to me, the clinical is how much can we walk? And, I think most patients can be able to walk a mile. And on the other part to help define that is when we get MRIs. And we'll get MRIs to see how bad the nerve compression is. And, it's pretty amazing. I'll see some patients who are, on the older side who have absolute critical spinal stenosis. And, they tell me they play golf 3 times a week. And it's amazing. Then I have some patients who have a bad annular tear with mild stenosis and they can't even get out of bed. So really the most important thing is, we treat patients, we don't treat the image. So it's all about correlating your symptoms, your complaints with how bad your MRI looks. So that's a long-winded answer to how I define severe stenosis. But just because you have severe stenosis on MRI doesn't mean you need to have surgery.
Thank you. Next question is intense pain in both buttocks, back of legs, and both calves more often caused from L4 to L5 or L5 to S1?
Great question. So classically, L4 will radiate to the anterior shin and to the medial ankle. L5 will come into the top of the foot, and S1 will come all the way down to the side of the foot. But everybody varies a little bit. So to me, my kind of basic way of defining it, if you have pain below the knee, numbness and tingling, more likely than not, you have something going on from L4 to S1. And we'll have to identify that with the MRI. The issue with the sacroiliac joint is that sometimes sacroiliac joints can present like an L5 radiculopathy. So that's a great question. To me, if it's buttock down the leg past the knee, more likely than not, it's going to be an L4 to S1 problem.
Thank you. Next question is 56-year-old individual, non-injury back pain, sporadic for over 10 years, chiropractic care and some PT. Alleviates pain short term, 6 to 9 months. What would you recommend at this point?
So for that particular patient, you need the workup done, and physical therapy, chiropractor can be obviously an option, but you have to understand what the actual problem is. And there are certain things that I believe physical therapy are very effective in, especially with muscular issues. Acute disc herniations are very effective. But in patients with really degenerative disc disease, bone on bone, or you have instability in the spine, you need to identify those issues. And it can be something as simple as an x-ray that we can take in the office. That we can help at least identify why you're still having recurrent back pain, because therapy and chiropractic treatment won't fix collapsed discs. It won't fix unstable spines. It can actually make things worse. And so, for that particular patient, I would strongly encourage them to get the full workup done, which would be, X-rays and potential MRIs, and then we can see if there's something else that we can offer.
Okay, thank you. Next question, are RAFs
Yeah,
used?
it's RFA. Yeah. So
Yes, okay.
yeah. So that is a option. The RFA is what we call the ablation for these joints. And what we're actually doing, the pain doctors are doing, is there's a small nerve that innervates the joint. And it's not the nerve that is going down the leg. It's not the sciatic nerve. It's just a small nerve that innervates the joint. And our pain doctors can go in and microwave that nerve. And again, the effectiveness of these are really kind of 50-50 in my opinion. I think it's something to consider if you still have issues after the therapies, medicines, and traditional injections.
Thank you. And our last question tonight is, why did you want to become a doctor in special orthopedics?
This is like my interview question when I was in residency. So, orthopedics and spine, in particular spine surgery, it's one of those fields where my mind works in a way where I'm very functional. So in a sense, what that means is, if there's normal anatomy and I see abnormal anatomy, my mind is not, I'm not very good at theoretical physics. I'm not good at abstract thinking. I'm very good at seeing a problem and fixing it. And, to me, one of the reasons why I went to spine surgery is patients who have significant spine problems, such as, weakness, intense pain, after surgery, patients are so thankful. It's one of those things where people can really get back to living. They can restore their life with appropriate spine surgery, and it's a feeling that I keep enjoying, even though I'm now a decade in, and it keeps me coming back to the office and keep wanting to help people with surgery. So
that's great passion, Dr. Lee. I do have one other question that just popped up, and that is minimally invasive surgery bilateral, September 2020 at L3-4. Now pain in front and side of thighs, never had before, less mobility than before surgery, was a walker and a hiker. Where is thigh pain, frontal coming from, afraid of suggested fusion, and had much PT. What do you
so, yeah, so that's a very, very common patient that we'll see. This is a good example of someone who's had a prior, sounds like a clean out procedure, a laminectomy. And at L3, L4, the nerve distribution actually comes in the front of the thigh, and sometimes a little bit into the knee. So it's very possible that you have some recurrent or residual stenosis at that level, at L3, L4. And you could have nerve compression a little bit different than what you had preoperatively. If you had a discectomy, that means the nerve was decompressed in the central part of the spine. But when that disc degenerates, the bones start to collapse on each other, and then the actual tunnel where the nerve comes out, it's called the foramen, can get very narrow. And it can get narrow because the disc goes away. It can also get narrow because you develop bone spurs in that tunnel. And this is probably why your surgeon is recommending a fusion, because it may require more aggressive removal of the facet joints to free up the nerve pressure that you're experiencing. So I'm sorry that you hear that you're not doing very well after the index procedure, but hopefully there's a solution for you.
Great, thank you. One last question just popped up. This participant was wondering if you can treat out-of-state patients.
Yeah, absolutely. So, as long as, what insurances we take, I will defer to our patient center, access center. One of the great things that we've been able to offer since COVID is telemedicine or televisits. So, I've had some patients come in from Scranton and New Jersey to see us. And a lot of times what I'll do for the follow-up is I'll do a televisit, and we can set up a Zoom meeting like this, and we can treat you there. So absolutely, we can take care of out-of-state patients. John can give you the information to our call center. And if you want to do a remote visit, we are happy to do that for you.
Great, absolutely fantastic, Dr. Lee. Thank you very much. I want to thank everyone again for who was able to join us tonight. For more information, or if you would like to make an appointment with one of our physicians in the future, you can visit us online at rothmanny.com or call us at 888-636-7840. And that's, again, for that last question there, you can call regarding any insurance questions that you have. And just a reminder, we'll be sending out a recording to all the registrants within the next few days, so please be on the lookout for that. You'll get a recording of this presentation. And again, thank you very much, and I hope everyone has a good rest of the evening. Take care.
Thank you, guys. Have a good night, everyone.